There we go. So this is a 72-year-old lady. She had not a very eventful medical history, just type 2 diabetes, hypertension. And she presented initially to an outside hospital for some memory loss as well as difficulty with her gait. The family reported that up until about February, and this was in May when we saw her, she was completely functional. I think she was working at the time, driving, was able to do all of her normal activities. And then early February, they started noticing she was having some more difficulty with her gait. She had some falls that were minor. She started to need some assisted devices. And then her family also began to notice sort of memory loss. She was putting things in cabinets that weren't supposed to go there, putting things under the bed, like food and things like that. And she started really to not be able to recognize other people except for really her family. And these weren't waxing and waning. These symptoms were constant and seemed to be getting worse. So she had a fall on the 1st of May and wasn't able to stand. And her family brought her to the hospital after that. And a couple of days later, she was transferred here where we met her for continued workup. On physical exam, it was mostly normal except for her mental status, where she was really just oriented to herself and kind of confused, had trouble conversing, but was able to follow commands. There were no focal motor deficits. She didn't have any ataxia for extremities, but did have very much difficulty with standing and walking. Her labs were really unremarkable. She had CSF that was sent for many things, but nothing came back at that time. And then her other all basic labs were normal. And she had some imaging that was revealing. So here's a MRI without contrast. We have the diffusion weighted on the left, and then ADC map on the far right. And then just wanted to highlight this area of restricted diffusion here in the right temporal or parieto-occipital cortex with a ADC correlate. And this is the flare here in the center that really at that time didn't show any changes. And this makes you think about a couple of things when you have this this pattern of restricted diffusion on the cortex. So if you have this on the cortex as well as the striatum or other parts of the basal ganglia, it's highly specific for Krutsvodyakov disease. But the things you may want to think about at this time could be stroke, obviously, but also a vasculitis or an infection too. So she had markers for CJD sent, and her RT quick did come back after she was discharged as positive. She also got an autoimmune encephalitis panel when she first presented, which was negative. So I just wanted to talk briefly about Krutsvodyakov disease. Down here in the right, I had fun reading about these physicians from the past. So here's Hans Gruber Creutzfeldt and Marie Alphonse Jakob here. But I think the pathophysiology is pretty fascinating because it's this aggregation of prion proteins in the cortex, and there are multiple ways that it can be transmitted. And as far as symptomology, you can get really a lot of symptoms that come from cortical degeneration. So things that mimic dementia, as well as other behavioral and personality changes. And depending on where you start having the aggregation or the encephalopathy, the spongiform encephalopathy set up, you can get symptoms there. And also the classic myoclonus, especially startomyoclonus. And then you can get some other signs, cerebellar ataxia, as well as even some rigidity similar to Parkinson's disease, extrapyramidal signs. There are several different types that I read about, which were very interesting. So most commonly we know sporadic type, and that's about 90% of cases. And interestingly, there is some predilection for that based on a certain gene that seems to predispose you to CJD, as well as another variation of that gene that seems to be somewhat protective. I think there's still a lot we don't know about that, but there's some implications in some protective as well as genes that make you susceptible to develop sporadic CJD. And then there are some well-described genetic inheritance patterns for CJD, and there's the acquired form. And there's subtypes of all of these that I didn't want to get into, but just realized that there are many different subtypes of each of these that have been studied. There doesn't seem to be a preference for gender. It seems to affect males and females about equally, and about in the 7th decade of life is when you see most people present. Although if it's genetic, that's usually a lot sooner or acquired, could be as well. And there are a few risk factors that have been identified, especially if you have a family history or genetic predisposition to CJD. And then they're outside of the genetic form. There doesn't seem to be an obvious geographic or racial preference. So as far as workup, really not the gold standard, but one of the most common tests we use is this fairly recently developed real-time quaking-induced conversion, which I had fun reading about, but it's very specific and sensitive. So if you have availability of that, it's the preferred test at this point. A little bit older, but still very good test is the 1433, although that can pick up some other dementias, and it's postulated that it may just be a marker of cell death and not necessarily specific to prion. And otherwise, the CSF is largely normal. You may have some elevated protein or rare cells, but that's not diagnostic by any means. And then imaging we touched on, but you'll see diffusion restriction, especially in the cortex. That's usually referred to as cortical riveting, as well as the striatum, caudate head, or the putamen. And that seems to be because of the spongiform pathology, although that's not very well known why there's diffusion restriction there. And the imaging is pretty sensitive, about 90% sensitive when compared to other dementias, but the flare changes appear sometimes a little later, and so you may miss early CJD if you get an MRI early. And the classic board question about the EEG pattern shows periodic synchronous bi or triphasic periodic sharp waves, and that's not that specific, but it can be used as supportive evidence. And on this particular patient, we did not obtain an electroencephalogram. And histologically, you see this spongiform pathology, and actually biopsy is the gold standard diagnosis, although it's not normally needed for these patients and is more of an academic exercise. And unfortunately, there are no known treatments, and care is directed at supportive as well as communicating with the family about the course of the disease, because the average time from diagnosis to death is about 6 months, even though symptoms may present before that. But by the time these patients get diagnosed, they usually live about 6 more months. And that's mostly referred to the sporadic form. There are my references.
All right. Well, thank you very much, Hunter. I appreciate it.
Yep.
Great presentation. Let me. Here's our CME code again. And next, I will turn it over to Dr. Massey to introduce our speaker today. Will be Vern Juel. Dr. Massey.
Yes. Can you hear me?
Yes, we can.
Okay. So it's with great pleasure that I present our colleague Vern Juel, who will be the speaker for Grand Rounds today. For those who have not had the opportunity to delve into his CV, I'll highlight a few things. He went to undergraduate at Grinnell in Iowa, so he's from the Midwest. He went to medical school at the University of Illinois College of Medicine, and then came to Duke for his internship and neurology residency, and we were fortunate to have him stay and do his fellowship with us. After that, he went to the University of Virginia on faculty and particularly developed an interest in education as well as neuromuscular diseases. We were fortunate to get him back here to be on faculty in the neuromuscular division. As you see, he has been prolific. He has 72 peer-reviewed journal publications and 18 book chapters, and he has participated in a number of position statements and has shown other types of leadership, including the as president of the American Association of Neuromuscular and Electrodiagnostic Medicine, which is for neuromuscular medicine, the pinnacle, and has served as, or serves as chair of the Consortium of Neurology Clerkship Directors for the AAN. He is currently the clerkship director, or has just passed that on for our group here, but has been very involved in the teaching program for the medical students, trying to make sure they understand that neurology exists and is very important. He has served as the Neuromuscular Medicine Fellowship Program Director for a number over a decade, and has fortunately for him, I think, found and trained someone, Carissa Gable, to do that. He's currently director of the Duke EMG Lab, and as Rich has put in this slide that he created, and has many other titles and awards. He is highly regarded throughout the world for his leadership and contributions to academics in neuromuscular medicine. So his lecture today is entitled "A Neurological Complication of Open Fractures." So Vern, I think we'll pass that off to you then.
All right, Janice, thank you for that very gracious introduction. I'm glad to be back for a number of years here. So let me see if I can share the screen.
Yes.
Okay, very good. So thanks for the introduction. I'm pleased to present one of the most interesting cases of the last decade, or at least it felt like that to me. So this is a case of open radial and ulnar fractures at the SAS soccer park in Cary. And before I get started, I need to acknowledge the others who were involved with this, characterizing this case. Andy Galbraith and Neil Johnson were our fellows in 2008, 2009, and spent a lot of time with this case. And of course, Don Sanders, who created the wonderful video you're going to see, and did some of the more sophisticated electrophysiology. So we'll get started with the case. This is this fellow had a hard fall out in Cary, and it was so hard that he sustained open fractures of his left radius and ulna. His ulna actually went into the dirt of the soccer field. So he was brought here for open reduction and internal fixation. And in the beginning of the procedure, copious irrigation was used along with some debridement to remove soil and grass that were in the wound. So this is the dirtiest wound possible. The patient received IV antibiotics for broad spectrum coverage, got a tetanus vaccine, and after the procedure was sent home on a 10-day course of cephalexin. 9 days after the fracture, he started having difficulty with vision. Vision was blurred. It hurt to look into lights. And within hours, that had evolved to frank diplopia with ptosis. 3 days after that, he developed dysarthria and dysphagia. So now, okay. So here are the fractures. This is the ulna that went into the dirt, and that was pre-plating, and that's post-plating. Okay. Now, I have to stop. Oops, I gotta stop the sharing first. All right, can you all see the video now? Okay, good. I'll play it.
Close your eyes real tight. Screens hard to get. Now open up real wide. Now puff out your cheeks for me. Stick your tongue out and wiggle it from side to side. Look all the way to your right. Now look all the way to your left. Now look up, and now look down. Look up for me now. Up as high as you can go. Now look all the way to your left. Now to your right. Good.
Okay, can everybody see slides now? Okay, good. All right, so I think the video says more than words can say, but this fellow had normal mentation. He was afebrile. You all saw the dilated and sluggishly reactive pupils, the marked degree of ptosis and external ophthalmoplegia. And he had severe flaccid nasal dysarthria. And this is one of the best, I think, depictions of facial diplegia. I mean, he has profound facial weakness, and I will show you the video of recovery at the end of the presentation, and you'll appreciate how weak his facial muscles are. But you know, eyes open, close eyes, show his teeth. I mean, it's profoundly weak. And interestingly, his limbs were not terribly weak, with the exception of the right upper limb. He had normal sensation, and his tendon reflexes were reduced in the right upper limb, but really weren't terribly remarkable. So this is the surgical scar, and we got this photo a little bit on the late side. So this is 9 days after his symptoms began and 2 days after he started IV antibiotics. And I'll have to say that this looks a lot more pink than it did before the antibiotics. This part of the wound was really quite devitalized and seemed to lack good blood supply, at least in the view of a non-surgeon. So it's not a great looking wound, but it looks a whole lot better than it did before the antibiotics. Okay. So this is the time we'll discuss Clostridium Botulinum. This patient's presentation raises great concern for wound botulism. So Clostridium Botulinum are ubiquitous in the soils. They're obligate gram-positive anaerobic bacilli. They have these heat-resistant subterminal spores, and the original description of botulism came from Central Europe with a Bavarian physician named Kerner, who noted the relationship between sausage poisoning or sausage ingestion and acquired paralysis in 230 people. The Dutch bacteriologist Van Erminghem also studied a group of cases of foodborne botulism resulting from raw ham consumption at a Belgian funeral music festival, which is sort of strange and ironic. So botulinum toxin is the most toxic substance known to man by weight. To put it into some perspective, a fatal dose in a human would be about 70 micrograms of toxin. So that is taken orally. Inhaled or given IM or IV, the doses are much smaller. So that would translate to roughly about 3,000 mouse units of the type A toxin in a healthy human. So that would be about 30 vials of what you've seen used in the standard onabotulinum toxin A in the clinic. So the toxin is heat labile. So if you heat it up for long enough, it destroys the protein, and UV light will also destroy it. And chlorinated water will destroy it too. But it's acid stable, and that has been a mystery for a long time. And the riddle was solved by a group at Stanford that reported that the botulinum toxin protein here in the lower right-hand corner is surrounded by this non-hemagglutinin protein called a bodyguard, which is an apt term. So it allows the toxin to survive the acid environment of the stomach and be absorbed. And with respect to the toxin, there are kind of three key areas. There's the heavy chain that allows binding to the surface of the motor nerve terminals. And then the mid portion here, the amino terminals allow translocation into the motor neuron. And then this is sort of the business part of the protein here, the light chain, which is a zinc endopeptidase that cleaves specific proteins associated with the movement, docking, and fusion of acetylcholine vesicles with the presynaptic membrane. So there are 7 known serotypes of botulinum toxin, and they're defined by their absence of cross-neutralization with antitoxins. So types A, B, E, F, and G cause human disease. C and D cause botulism in animals. And so for those of you that raise ducks, the disease Limberneck, which is duck botulism, is a big issue. So you've got to make sure they're not eating things that are decomposing or decomposing insects. All right. So each serotype of toxin is a zinc endopeptidase that cleaves one of the key proteins involved in the movement, docking, and fusion of the synaptic vesicle filled with acetylcholine with the plasma membrane. So there are some of the proteins are, some of these proteins are related to the vesicle themselves. So the synaptobrevin protein, for example, which is cleaved by botulinum toxin B, the main one for human disease, and these others, as well as tetanus toxin, is associated with the vesicle. And then syntaxin and SNAP25 are proteins that are associated with the plasma membrane, and they're cleaved by toxins A and E. So it's interesting and how type B botulism is not as severe as type A botulism, And there's been some speculation about whether that relates to the body's ability to make new vesicles, maybe easier than making new plasma membrane, but that's just speculation at this point. So recovery from botulism has always been thought to owe to sprouting of new motor nerve terminals to the muscle end plate region. And not so clear that's the case with the botulinum toxin B and the others that attack synaptobrevin, but it does seem to be the case with type A botulism. And so this is an example of resprouting of motor terminal nerves with botulinum type A. Okay, so the main clinical features in botulism are this symmetrical descending paralysis, which some may construe as multiple cranial neuropathies that evolve fairly rapidly over hours. Patients inevitably get blurred and double vision, ptosis, dysarthria, dysphagia, and ultimately dyspnea. But botulism does not cause fever, and it does not directly cause a change in the level of consciousness or sensorium unless there's respiratory failure. In foodborne botulism, patients, and I'll talk about that more in a moment, but patients ingest both toxin and bacteria. So there's oftentimes a lot of GI upset and local autonomic dysfunction within the GI tract. With infant botulism, and I'll talk about the mechanisms in that in a moment, often the initial symptom is constipation. And as I alluded to earlier, type A disease is associated with more prolonged ventilatory failure, so almost 60 days compared with type B disease. And type B and E disease are associated with more autonomic dysfunction. So this was a 40-year series, probably the largest series of botulism cases, comparing the signs between types A, B, and E. And I think the thing that sort of stands out is how type B and E disease really cause a lot more autonomic dysfunction as manifest at the pupillary level. So differential diagnosis includes variants of Guillain-Barré syndrome in particular, so Miller-Fisher syndrome and the cervical brachial pharyngeal variant associated with the ganglioside or GT1A antibodies, myasthenia gravis, Lambert-Eaton syndrome, tic paralysis, and other subacute brainstem lesions. The normal sensorium obviously mitigates fairly strongly against the acute brainstem lesions. Differential diagnosis for the infant intestinal form includes sepsis, meningoencephalitis, congenital myasthenia, SMA, and metabolic disorders. So let's talk about the flavors of botulism. So as I started out with, foodborne botulism was the original recognition of botulism as a disease in humans. The mechanism for that is that people ingest preformed toxin from contaminated food sources. And because of that, the disease, foodborne disease, can present in outbreaks. Intestinal botulism, which is most commonly infant botulism, involves ingestion of spores of clostridial bacteria in a susceptible population. For instance, infants that don't have normal coliform bacteria that provide the opportunity for the Clostridia to germinate in the gut, and then the infant absorbs toxin. There's some circumstances with adults that this can also occur. I'll talk about that in a moment. Interestingly, infant botulism was only first recognized in 1976, so it's obviously been around for all of time, but good astute observation allowed it to be recognized. In wound botulism, as we suspect in this particular case I just presented, devitalized tissues that are relatively anaerobic become colonized, and there's in vivo toxin production and circulation of toxin. Inhalational botulism is exceptionally rare with absorption of aerosolized toxin through the alveoli. And then the latest, greatest clinical form of botulism is iatrogenic botulism in the context of therapeutic injections. So with foodborne botulism, the foods that are most often implicated are vacuum packed or home canned foods that are non-acid, so particularly fish and green beans. So you want to make sure that the person doing the canning has a pretty good MOCA score, so you don't come down with botulism from the home canned stuff. Pruno, which is wine made in prison from all sorts of things, if it's stored in an airtight container, can result in a number of outbreaks of botulism. That's interesting. The the majority of foodborne botulism cases in the US are related to fermented native Alaskan foods. And I'll talk more about that in a minute, but they have been the leaders in foodborne botulism for the last decade and a half. The other thing to point out is the geographic distribution of foodborne disease reflects very closely the type of spores that are distributed in the soil in that region. So for example, type A botulism is very common in California, Nevada, Utah, and the western states, whereas type B botulism is quite common in the Allegheny Mountain region of Pennsylvania and West Virginia. So when these cases are, the index case often takes a while to be recognized, and so the fatality risk is highest for that case. And then once people are on to the outbreak, the subsequent cases fare much better. So why so much foodborne botulism in Alaska? Well, the Inuit do a lot of fermentation in their food preparation of fish and seal and etc. And it's interesting when you look at this curve from the Alaska Department of Health. There were very few cases of botulism until they got plastics and glass containers in the 70s, and thanks to these modern materials, the Inuit adopted a practice of putting the meat in the airtight container, so creating the anaerobic conditions for botulism to develop. So there's actually a big public health effort in Alaska to, if you're going to do fermentation, don't use plastic or glass jars, and be completely traditional and go dig a hole in the tundra and put your stuff in there. There have been some outbreaks associated with eating beached whale in Alaska too, so stay away from that. Just say no thank you when beached whale's on the menu. Wound botulism was previously very rare, but the number of cases went up in the early 2000s because of a practice of skin popping of black tar heroin. So that practice creates a fibrotic, devitalized, poorly vascularized region that is the perfect environment for clostridial spores in the black tar heroin to germinate and for you to absorb toxin. So black tar heroin is probably a little bit of heroin and a whole lot of dust, coffee grounds, wood shavings, and probably a little bit of botulinum spores too. So So probably not good to use the black tar heroin. In wound botulism, the patients do not have the prodromal gastrointestinal symptoms like they would when you ingest the toxin and absorb it, or when you ingest the spores and they germinate. And sometimes, depending on if the infection is extensive, you can have fever in wound botulism, but that's minority of the cases. So infant botulism is almost as common as foodborne botulism. And again, the infants ingest spores, they germinate, they colonize the large intestine, and the infant absorbs the toxin. And this sort of goes back and forth with foodborne botulism for being the most common. Most of the cases are in California, and most of the cases are type A. And so the susceptible age seems to be about 13 weeks to 15 months. Honey is the most significant source of these spores, because if it's not been treated, infants will ingest the spores and can't develop botulism. So type B disease isn't as bad as type A disease, as is the case with all the other forms of botulism. And pediatricians recognize this pretty readily, so the case fatality rate is very low. There's an adult equivalent of this that can occur when there's low acid in the stomach, or oftentimes following large surgical procedures involving the GI tract, in which the intestinal flora are all eliminated, providing an opportunity for clostridial spores to move in and germinate, since they don't compete with other coliform bacteria. So given that this occurs in the context of people who are very sick from many other perspectives, it's probably under-recognized and underdiagnosed. Okay, so inhalational botulism is something that raises great concern for bioterrorism. The 3 known cases of this that have occurred related to workers in a laboratory that were disposing of animals that inhaled the fur and developed botulism. So there was a near miss in the 1990s with the Shinrikyo cult that had plans to release aerosolized toxin in the Tokyo subway that was fortunately thwarted. Iraq under Saddam Hussein had large quantities of botulinum toxin that were never used, fortunately. So our defense planners are very concerned about this. So if there are numerous cases, especially cases with unusual serotypes of toxin that have a common geographic factor, but without a dietary exposure, that raises suspicion for bioterrorism. Okay, iatrogenic botulism is related to therapeutic use of botulinum neurotoxin, and this does not reflect a situation where there's untoward regional weakness. So for example, patients getting injections of botulinum toxin for blepharospasm or hemifacial spasm that may develop ptosis because of local diffusion of the toxin. This relates to more distant spread of toxin with distant paretic muscles and autonomic dysfunction. And so single fiber EMG, even when there's not clinical iatrogenic botulism, can detect jitter in the distant muscles. So the most flagrant example of this was in 2004, when this fellow, who was running a laser hair removal clinic in Fort Lauderdale without a medical license, happened upon some research grade toxin that was much cheaper than the pharmaceutical grade toxin, and administered it to this fellow, his wife, his own wife, and to himself. And they somewhat overshot the dose, Actually, almost 3,000 times the human lethal dose were administered, or at least on the estimates of the CDC investigators. All of the individuals spent at least a month on the ventilator, and this fellow did some time at the federal prison in Atlanta for drug misbranding. I don't know if he's back in business or not. But this is a table I've copied from the paper about those cases. And one thing I want to point out, they all got the injections around the same time, but patient number 1 here did not get antitoxin for about a week after all the others did. Okay, and what a difference that made. He spent 171 days on the ventilator versus a little more than a month for the other ones. So while the clock was ticking, the toxin was binding to the motor nerve terminals and shutting down neuromuscular transmission. So one thing I do want to emphasize is expeditious recognition of botulism and expeditious administration of antitoxin is really, really important for outcome. All right, so the diagnostic studies that are currently available include electrodiagnostic studies, and I'm going to talk a lot about the studies that were done on our particular case. So while the findings aren't specific, they are very readily available, and they're available in a very timely way. The mouse bioassay, FDA approved, is the gold standard, but a lot of resources are required and the findings are delayed. PCR can detect bacterial genes, but not toxins. So if you can, if a patient ingests Clostridial bacteria and toxin, and you aspirate gastric contents or look at stool, you can do PCR on it. And if you're lucky, you can detect the genes for that particular serotype of Clostridial bacteria. Mass spectrometry is promising, but it's only available at the CDC at the moment. So the classic finds in electrodiagnostic studies are low CMAP amplitudes, small motor unit potentials that are unstable on concentric needle examination, sometimes abnormal spontaneous activity. So, so for those of you who are going to be taking the neuromuscular medicine board examination, listen very closely. Unlike other junctional diseases, low frequency rep stim rarely shows decrement, unlike more common junctional diseases like myasthenia and Lambert-Eaton syndrome. There is post-exercise facilitation, but it's usually not as prominent as in Lambert-Eaton syndrome, but it is sustained. And it's more prominent in proximal muscles, and for whatever reason, it's more prominent in type B disease. That's probably not so important. So this is an example of a 50 Hertz train of repetitive nerve stimulation for 2 seconds in infant botulism with 78% sustained tetanic facilitation. And here are the findings in our studies at 5 days after the symptom onset. So again, as is the rule in botulism, we see really minimal decrement stimulating the ulnar nerve at 3 Hertz and recording in the ADM. Same thing with the APB, 14% decrement, so that's abnormal, but it's not shockingly abnormal. But the facilitation is pretty significant. So in ADM, we had 115%. We went from a low amplitude of 4 millivolts all the way up to 8.6. And in the APB, starting out with the low amplitude of 2.1 and going up to 4.9, so 133%. So very cool. And Don very nicely showed the motor unit potential instability in a rastered group of motor unit potentials. So you can see that every time this motor unit potential fires, its configuration is altered in some way because the muscle fibers that compose it are variably responsive due to the neuromuscular transmission disorder. We see this one component drop out completely here, reflecting probably a great degree of neuromuscular blocking. Now, the most sophisticated thing one can do is stimulated single fiber EMG that shows a rate-dependent jitter. Okay, so as the frequency of motor nerve firing increases and the presynaptic calcium increases, the likelihood of release of acetylcholine increases. So you can see in this panel, stimulating at 10 hertz, we have a one muscle fiber potential here and another muscle fiber potential that's almost always blocked. And when we increase to 20 hertz, all of a sudden we see it come back in. And in our case, Dr. Sanders showed here that at 10 hertz, we improved our percentage of normal jitter by double here. So this is what you want to see in a presynaptic junctional disorder. So for autonomic testing, we previously did RR interval testing, and this was done as a surrogate for small fiber neuropathy. We're doing skin fiber or core skin biopsies for epidermal nerve fiber density testing. But we used to do this with a paced breathing maneuver. And so normally, this would be a normal person here. The heart rate variability is pretty significant during the paced breathing maneuver. And in this particular patient, the variability is minimal. Okay, so that demonstrates the autonomic dysfunction in botulism. So the mouse bioassay is conducted through mouse colonies at the CDC, and in North Carolina, at least back when we had this case, North Carolina contracted with the CDC to run a mouse colony on its behalf. Some states have their own. So you have to have a lot of mice to do this. You have to have 7 type specific, you have to inoculate your mice with 7 type specific anti-sera. And then depending upon how many samples you have, like if you have gastric samples, if you have stool samples, if you have serum samples, it just multiplies the number of mice that you have to have. Now, obviously, if the mice die, that tells you that they didn't get the appropriate anti-serum. But there are technicians that are trained to look for signs of mouse botulism. So this is one of the signs of mouse botulism here. This is called the wasp waist sign. And this is literally paradoxical breathing in a mouse who's got diaphragm paralysis. So this is the kind of paradoxical breathing version in mice that is looked for in the mouse bioassay. So management involves giving antitoxin as expeditiously as possible. And the dose of antitoxins are several-fold higher than necessary to neutralize the highest known levels in botulinum toxin intoxications, but higher doses could be necessary if you got a very, very large dose or in a bioterrorism event. So things that augment neuromuscular transmission that we use in myasthenia gravis and sometimes Lambert-Eaton syndrome are not terribly effective. So botulinum antitoxin heptavalent, which was approved in 2013, it's available through the CDC. It is of equine origin. Okay, so there are people that have hypersensitivity reactions to that are severe. And for infant intestinal botulism, there is a human immune globulin that's bivalent against types A and B that's available from the California Department of Public Health. And humanized monoclonal antibody therapies are or have undergone phase 1 testing. Actually, there have been a couple of phase 1 trials in the early phase research unit here at Duke that Drs. Guptill and Raja have been running. So you report cases to the state health department and to the CDC. The patients get supportive care. If you suspect contaminated food, you can give activated charcoal or purgatives, and you want to avoid antibiotics that impair neuromuscular transmission. So in our particular case, the electrodiagnostic studies were compatible with wound botulism. This was in 2008, so patients were getting a bivalent equine toxin, so for type A and B. And so this was given 6 days after onset. I'll tell you all a story about how Bill Galantine, one of our pediatric neurology faculty, drove out to RDU to get this bag of antitoxin sometime. It was recommended that the patient undergo surgical debridement and removal of hardware, but that was deferred. The antitoxin was given. The patient got tremendously better within 24 hours. It was really quite remarkable. The mouse bioassay from the serum samples was negative, and the patient developed osteomyelitis 6 weeks later and finally underwent the surgical debridement and hardware removal. All right, so let me show you the follow-up video. Okay, here we go. Can you see the video?
When did you go home from the hospital? A little over a week ago. Do you have any double vision now?
No,
Do you have any weakness of your eyes?
it's blurry.
A little blurry, but no double.
No,
You have any trouble opening or closing your eyes?
no, I don't have a problem.
How about your chewing or talking or swallowing?
No, 100%, but I was thinking it's 80%.
Your swallowing is 80%.
Yeah, 80%.
You get tired chewing?
No,
Okay. And how about your arms and your legs? Strength there?
I feel more strong this arm.
Feel stronger in the right arm than in the left arm? Yeah. So it sounds like things are much, much, much better. Is that a fair statement? Much better than when you were in the hospital?
Yeah, it's 100% was better.
Yeah, much, much better. When did things start to get better? So a couple of days after we did these tests the first time, you started to get better. Okay. When did you get as strong as you are today?
Every day is
Every day you get better.
It's more better. It's very slow.
Yep.
This is no change, very slow.
Mhm. Today, his strength is pretty full throughout, and his reflexes are
Present.
present throughout, symmetric, a little bit hypoactive. Close your eyes real tight, squint them really hard together. Good. Now open them up, way high, wrinkle up your forehead, like up and down like that. Good. Stick your tongue out for me now. Wiggle it from side to side. Okay, good. Now show me your teeth like this. Great. Look as far as you can off to the right. Now look as far as you can off to the left. Now look straight up as far as you can go. Up.
Okay. All right, good. So we're about out of time. So just to sum up, botulism is a rare presynaptic neuroparalytic disorder, clinical presentation with descending paralysis with ophthalmoparesis, dysarthria, dysphagia, dyspnea. Mentation is normal, there's no fever. Electrodiagnostic testing can expedite timely diagnosis and treatment, and outcomes are better with expeditious antitoxin treatment. Okay, all right, I'm going to stop share. Let's see. Jim Burke had a great question about has the incidence of ingested botulism increased with the use of acid blocking drugs? I don't know, but that is a good question. You would think that it might be, but I don't know. Let's see. So let's see other questions. How many cases of non-iatrogenic cases of botulism have been seen since 1980? From Kivan. I don't know. That would be a very good thing to go to the Slicer Dicer program and see. This is the only one I'm aware of, but I suspect there's some pediatric infant botulism cases. I saw more when I was in Charlottesville. I saw a couple of cases there, and there was one here of somebody with some bad canned green beans and a mini mental status score of about 20, foodborne case here in the mid 2000s. So, okay, let's see. I think I covered most of the questions.
We have one more from how often is pupillary paralysis present with facial or generalized paralysis due to Botox?
Oh, I have not seen that, but I don't know if Janice is still on. So she's seen a lot of cases of ophthalmoparesis and ptosis from injections in and around the face and from migraine. I've never seen internal ophthalmoplegia or any pupillary abnormalities with that. Have you?
No, but it's not as common with type A as type B anyway.
Yeah.
So.
Yeah. Not as much autonomic, and actually when for injections, therapeutic injections for sialuria and ALS, the type B toxin is preferred because it has a better effect on autonomic function, or more profound effect on autonomic function. So,
and you mentioned that there is an ongoing studies for a monoclonal antibody. Is that specific for individual toxins, or is it to find multiple toxins?
So there are actually several parallel studies that are being conducted to develop monoclonal antibodies, and the two of them have been done through the DEPRU here, and they're contracted out from the division of NIH that develops vaccines. So presumably, where that's going is there would probably be a mixture of monoclonal antibodies to cover all the serotypes of botulism, because the problem is on the diagnostic end, we don't know what kind of antitoxin to give, because we're so delayed in determining what serotype is causing the disease. So therapeutically, we have to cover for all of the potential serotypes. So I think,
Gotcha.
I didn't get into this, but to maintain a national supply of antitoxin, I mean, there's a horse farm that they are doing essentially pheresis on horses to get equine-derived antitoxin. So that's that's quite an operation, and obviously, if there were some sort of bioterrorism event, I don't think there's probably enough antitoxin in the nation to take care of that kind of problem. So, and I'm sure there are expenses in keeping the horse farm and all that. So for the infant botulism, the baby big that is supplied by the California Department of Public Health, they actually immunize human laboratory workers and freeze them. And that's how that antitoxin is acquired.
Wow.
So anyway, a part-time, I guess if the office work gets too slow, that's always not.
If I could just add one, I think, interesting comment. I had a patient who had worked in the military, and I don't recall his specific job, but there was concern that he might be exposed to the toxin, and so he worked at Fort Detrick in Maryland, which is the place where antitoxins and toxins are embraced and studied and such. But he had been immunized against botulinum toxin there as part of his work, and then he developed dystonia. So I got to prove that their antitoxins do work, because he had no response to any botulinum toxin.
Unfortunate.
Yeah, very unfortunate.
He should work for the California Department of Public Health then, right?
Yeah, yes.
Get freeze, donate his plasma to them.
Yeah.
So, okay.
So, and for all the young mothers and fathers, or not young, but all the mothers and fathers of young babies, don't forget that you don't want to buy honey for the baby that has not been processed or filtered or whatever. You do not want raw honey. We've seen an occasional case of that. So I've just had this discussion with my children recently, so about their babies. So anyway, so that's my comment.
All right. Well, thank
Very
you so
nice.
much, Dr. Juel, for this fabulous talk.
Good. Thank you. Thank you. Okay, take care.
All right. Bye-bye, everybody.
Bye.